This is the Cancer Interviews podcast, and I'm your host, Bruce Morton. The topic of patient advocacy comes up frequently on our interviews. On this episode, we're going to address this important topic, but through the eyes of a doctor. He is Hardeep Phull, MD of San Diego, California. What he has to say may surprise, but it will definitely inform you. So here he is, and Hardeep, welcome to Cancer Interviews.
Hey, Bruce, it's such a pleasure to be here this morning and talk to you about this important topic.
Thanks so much. And what we want to do at the beginning with you is what we do with all of our guests, and that's to learn a little bit more about them. So if you would, tell us a bit about your background in medicine.
Absolutely. I started my journey early in Arizona, growing up in Arizona, and did a lot of research in urology and neurological cancers. Eventually went to medical school in Cleveland at the Cleveland Clinic. And back then I was meant to be a surgeon, or I thought I was, but I eventually found my passion in medicine and specifically in oncology. My mother was actually an oncology nurse at the VA hospital where I volunteered, when I was getting hours for community service for my pre-med applications. So I still have a very big heart for the VA and that population. But it was a full circle, and I've been back in oncology and since 2011, basically, and practicing full-time in San Diego. I'm a general hematologist, oncologist, so I see a wide variety of cancers now.
In a broad brush sort of way, Hardeep, how might patient advocacy appear differently through the eyes of an MD as opposed to that of a patient?
Absolutely. First of all, I empower all patients to both have advocates for themselves and to be their own advocate. As physicians, we're also, supposed to help patients advocate. In other words, be their advocates. The most common scenario there is to advocate on their behalf for insurance companies, especially when we're trying to get important studies done, or be their advocate for other things, including, let's say, a patient's trying to quit smoking or another habit, like let's say alcoholism. By being their support system and advocating for them and helping them, showing them that we have their back, we greatly empower our patients to take control of their lives again.
Again, speaking in a general sort of way, are there red flags a patient should look for, red flags that would necessitate patient advocacy?
I would say red flags are, a patient who's struggling to get things done. Often we label these patients, unfortunately, as non-compliant. Let's say, why didn't you do your scan in time? Why didn't you get this study done? How come we're taking so long to start this treatment? Or why didn't you show up for an appointment? These are signs that someone's struggling, either with understanding the diagnosis, the logistics of treatment, or having financial or even food insecurity. I'll tell you, there was a patient just the other day that I saw who was sitting in the lobby, and there was there happened to be food that was brought in, and all he could do was, sit and eat sandwiches and watch the TV screen. And we thought right away, this guy nutrition is more important to him right now than cancer. And if we don't feed his soul and give him energy, he's not ready and prepared to talk about chemotherapy. And so for him, every time he came into an appointment, we actually had some sort of food or treat ready for him, and I'd be waiting in the room, and he started looking forward to these appointments. And then he opened up more. Nobody likes to admit, when they're checking into an office, hey, I've got food insecurity, I can't afford things, I'm on food stamps. But when you empower people in that way and you realize, okay, they have a struggle, we're going to help them, then they open up more, and then you see the real person behind the illness.
By the way, we're confident you'll be able to learn some tips and tools to help you through your personal cancer journey. But first, we'd like to invite you to please give us a like, leave a comment or review below, and share this story with your friends. Kindly click on the subscribe button below and click on the bell icon so you'll be notified the next time we release a cancer interview. And if you or a loved one are facing a cancer diagnosis, please click on the link in the description and show notes below to check out our free guide, The Top 10 Things I Wish I Knew When I First Got Cancer. Finally, we want to remind you that on Cancer Interviews, we are not purveyors of medical advice. If you seek medical advice, please contact a licensed healthcare professional like Hardeep. Now, Hardeep, I want to take this a step farther and ask, are there certain situations that go a step farther, that rise to the level in which a patient must switch doctors?
It does happen. It happens frequently. It could either be because they need more specialized care than, let's say, I can provide, nowadays cancer is getting so complicated. Even when I started training, yes, there were rare cancers and common ones, but in general, the published treatments, there were likely one or two. And if you fail the first one, you do the second one. You fail that one, we might have trials for you. Now it's like every cancer is its own subspecialty, and people do sub-training and sub-fellowships and specializations. So some doctors may do only one or two cancers, and that's all they specialize in. They won't see anything else. Of course, they're going to be more specialized and trained than I am in trying to keep up with that specific field. And now, with so many trials and drugs being approved, many of the tools we have are being combined up front in very interesting combinations. For example, previously we had targeted treatments, immunotherapy, and chemotherapy as the main three, let's say, options. Now we can combine sometimes all three of those at once and hit the cancer hard up front, and then still have backup options later on while we test patients' DNA mutations. When I first started training, doing genomic sequencing of someone's cancer and their own genome cost tens of thousands of dollars. Now that's a copay of less than 100 typically. And we can even talk about advocacy. If a patient can't afford that, we can even advocate for them and get that free. So what an amazing time to be targeted and intelligent about the precision medicine and treatments we pick. But going back to your original question, are there other times besides that where I don't have enough information or a patient desires more expertise? Absolutely. My ego is not so big that I think I'm the end all be all. I sometimes encourage a second opinion at the beginning just to have a reassurance, even though I know that other doctors' plan is going to be the same as mine. It helps a patient to understand, okay, they agree, and, sometimes even to know regionally and nationally, people have differences in practice slightly. So I have a lot of patients who call their friends back home if it's on the other coast, or a doctor friend, let's say, not always an oncologist, but another friend to say, does this sound reasonable? And I'm often the subject of those such calls where my colleagues are seeing a patient or, a relative or friend, and they just want to talk to me. And I don't even have their case or reports, but they want to sound it off me and say, does this sound reasonable? And I see the reason patients want that. It's can I have reassurance that my own family member and friend agrees that this is the right thing to do? So I highly encourage that. And then the last thing is, like you said, we kind of talked about clinical trials. There's sometimes clinical trials only available at certain academic centers. Some patients have to drive 100 miles or more if they're living in a rural area. But if it's the right fit and there's no other options, or it's a better option than the standard of care, despite the transportation burden for some of our patients, it is actually good to do clinical trials. We can talk about this later, but patients are not guinea pigs. Clinical trials combine the standard of care with a newer form of therapy, and that's how we innovate cancer care. Clinical trials are the way we find cures and new treatments. So for the right patient, especially the one who's failed a treatment or is not doing well on conventional therapy, I highly recommend trials, and I have no problem referring people to see other doctors that do specific trials.
And Hardeep, we want to get into the whole notion of clinical trials in a little bit more detail a little bit later. Same for doctors advocating for insurance coverage for certain procedures. Want to get into that as well. Now, allow me for just a second to get off topic, and I will quickly veer back onto the road. But in a previous professional life, I worked in the hospitality industry for a major hotel. And anybody who works in a major hotel learns that guests love to complain. In not all, but many instances, the magnitude of their complaint was out of proportion with the magnitude of the alleged transgression. To get back on topic, can a patient hamper the treatment process with, for lack of a better word, overzealous complaining?
Certainly. When patients come into our office, not all of them have a serious cancer. Some have a benign blood condition. But the problem is, the referral form often says on there, oncology. And of course, someone's mind goes racing about what it could be. How did they miss this? Why is it now? I had this cough for months. How come nobody paid attention? Now it's cancer. It's very easy for people to go into that phase of maybe regret, maybe guilt, blame. I think everything is a process. I think people go through phases of coping with news, whether it's bad news or unexpected news. My goal when I meet a person like that for the first time who's not having their best day, whether they're complaining or not, is just to have empathy and to realize that person's extremely scared. I walk into the room with a smile. I tell them what's going on. I give them the facts and tell them what it's not. And I tell them when there's something to fear or something that's serious and something that's just, by the way, we'll watch this. I think just having that knowledge and empowerment helps patients overcome that blame game. But sometimes it is warranted. I mean, like you said, it is a service industry. There's so many times when physicians are running behind. Let's just imagine I have a 20-minute slot to see someone that takes 40 minutes. Now that next person is missing work and has somewhere else to go, and now they're waiting an extra 30 minutes for me. They're already kind of anxious. They got up super early that morning to make it to the appointment. Now I'm making them late, and then the patient after that late, and it's like a cycle, right? I've seen that happen too. And so in that case, what can you say except the front office can be trained to say, we're sorry, he's running behind, there's other patients. And I think our patients, as they come in more frequently and they see this happen and they see other less fortunate souls in the lobby who also need care, most people, I do believe, have goodness in their hearts and empathy, and they realize, okay, he's going to take care of me. I'm so happy this doctor is taking care of others so well that he's running behind. It's not that he's lazy. It's like he's spending time with patients. So the bottom line, Bruce, like you said, yes, there's going to be complaints. Sometimes it's unwarranted. I'm never really going to call out a patient and say, you know what, that's unwarranted. Stop complaining. I'm going to talk to him and say, why do you feel that way? And what can we do better? I'm sure in the hospitality industry, Bruce, I'm sure you did an amazing job and did the same thing. And it's once you take that tension out of the air and you help meet the client, let's say, at their level and see where they're coming from, I think they just want their voice to be heard.
And you're absolutely right. Empathy can be a very good ingredient in good guest outcomes in the hospitality space, just as it can in the medical space. Now, in terms of the kind of patients you encounter, I want to go in the opposite direction, in a positive direction. Hardeep, on our program, we recently had a guest who vowed to be the best patient he could be by way of diet and exercise, by taking his medications when he was supposed to take them and in the quantity he was supposed to take them, and by listening to his doctor. He wanted to position himself for the best possible patient outcome. Does this speak to a different sort of patient advocacy?
I celebrate all patients' efforts to take control of their life, whether it's diet, exercise, or some mental health. By the way, I also tell my patients that be balanced. Don't go, to any extreme. The worst thing that some patients do with a new diagnosis is they punish themselves. They start eating things their body's never been used to. I call it, let's say, the kale diet, really heavy, tough foods to digest because they're purported health benefits, high fiber. These are great things. Great. I'm glad you're eating them. But feed your soul. You're going through a very difficult time. The body responds wonderfully to taste and smell and comfort. Comfort foods are that for a reason. And so, sometimes when a spouse is with a patient and I say, I use this term, I say, well, do you remember if this was a female, I say, remember when your wife was pregnant and she told you to go to the grocery store and get her anything her heart desired and had a craving for something? This is the time to pay attention to your cravings. Because on chemotherapy, let's say, your taste buds change, your taste, your smell, what you like, what tastes salty or sweet changes. So feed your soul. Yes, be compliant, try to eat balanced, try to be active, but be gentle with yourself. There's days you won't want to be. And so for that I don't want to call it overzealous, but that over compliant patient who's trying to do everything right, I say, take it easy, take a few breaks. Don't set such a high bar, because that over control also can lead to problems when you lose control, when you try to do everything right and there's an unexpected outcome. So, the bottom line is we encourage all these healthy habits and we just provide a little bit of extra tips to keep people sustainable for a long-term journey rather than a short-term marathon or sprints rather that fails.
Our guest is Hardeep Phull, MD, out of San Diego, California, and he's talking to us about patient advocacy through the lens of an MD. And Hardeep, I want to get into this two-part area. We've already addressed it to some degree, but want to go into a little more detail if we can. First of all, the notion of clinical trials. Is this something that doctors can advocate for on every basis or in every case, or must this be handled on a case-by-case basis, and some cases are stronger than others?
Absolutely. Bruce, it depends on the type of cancer, the stage, how rare it is, whether this patient is failing first-line treatment or not tolerating it, or if they're on their last legs, and they've tried multiple conventional things and they're failing. The wonderful thing nowadays is with this genomic testing I was alluding to earlier, many of these uncover new mutations we've never heard of or things that there's trials for. And they often have reports on the back of what trials would match a patient's specific mutations. So that's one way a patient can quickly learn about what's going on. The other way is there's websites like clinicaltrials.gov where patients can see, okay, in my area, my region, what are they studying? And is there anything in my cancer type? There often is, by the way. And the key is to tell every patient, you have to meet these eligibility criteria. If you're the runner of a clinical trial and you just take all comers, your clinical trial will fail. You have to put a very specific question and scope. This type of patient at this age group with this cancer and this first treatment, or treatment naive. You know how many trials are no prior treatment? That's the first line. So if you don't meet those criteria, it's not like, oh, you failed and there's nothing else. Something else will come along, but you have to be an appropriate candidate. And you have to equip such a patient to realize it's not just you show up to this clinical trial center, usually a university, let's say, and you just go in and they're like, okay, sit in chair number 1. There's the trial drug. There is incredible amount of safe protections for patients. We don't want to give patients drugs without consent, without them understanding the risks, the benefits, the alternatives, and the intent of the trial, understanding what the drug is, what the mechanism is. It shouldn't be just say, oh, here's a miracle drug and you might get placebo. It should be, here are the potential options, the potential side effects, and explaining the trial. That takes time. And most trials require what we call washout. In other words, if they had prior chemotherapy, there's a certain amount of time that chemo has to be out of the body before you start a new drug. Or they require certain types of blood testing or certain scans. So, of course, we want all our patients to have all the knowledge and accessibility to trials, but I often equip patients with all of this knowledge so they understand it's not a simple show up and you get your trial done. It's you'll show up, you'll be screened for a trial, and if you're a candidate, you'll go on it. And I'm a big advocate, by the way, of trials because I know today's treatment is amazing, but I know in 10 years it'll be even better. There's no way to accomplish that without trials.
Hardeep, to some degree, does this place the onus on the physician to stay as up-to-date as possible by reading the New England Journal of Medicine or other trade publications, so they are as on top of all things clinical trials as much as possible?
Absolutely. Not just clinical trials, but just knowing what's out there and what's developing in the field. Some doctors do this via conferences. There's annual conferences all throughout the country. There's board review courses. There's conference reviews like the best of ASCO, best of ASH. That's the best of an entire conference where there could have been thousands of abstracts and presentations. Then there's, online resources which condense, the knowledge into, let's say, 3 or 4 pages as a summary. The best way for me to do this, and it's really hard to do with the field growing so fast, is to get digests of information. So I subscribe to Journal of Clinical Oncology, New England Journal, and then I do like best of type digests. But something else, doctors learn from each other. The collegiality and having friends and colleagues because you both want to learn, is an incredible source of empowerment and knowledge. You learn through tumor boards where you're talking about cases with other doctors. You learn from your friends and colleagues across the street who are using a let's say, a newer version of a treatment, or you say, what would you do in this case? I'm thinking this. So running it by your colleagues. People will realize at some point, they say it's clinical practice. It's not because we're practicing on patients, but because it's an art of medicine. There's many choices in the toolbox. What is the right one for the patient in front of you? That's always the question. That's what AI can't answer. That's why a doctor, someone who knows the patient and knows their preferences and what they'll tolerate, can answer. So there's incredible sources of knowledge all around us. And I think most physicians are just extremely happy to learn, overwhelmed to learn, so they have to kind of limit their scope. That's why some specialize in certain cancers, and they just can't keep up with every cancer known to mankind. They say, I'm going to do these 2 or 3 really well, or this one really well.
Now, I want to talk about another phase of patient advocacy that crosses the line over to that of the exam room and the doctor that occupies that exam room, and that's insurance coverage of a certain procedure. We've heard from time to time from patients who are lay people saying that that a doctor can make their case far better than they can. Your thoughts on that?
And you're talking about, I'm assuming, insurance denials and appeals.
Yes.
My favorite topic, It's always appalls me sometimes when I get these denials or rejections, especially with the wording of it. It's often not worded in the most compassionate way. They send a letter to the doctor's office and the patient. You can imagine what a patient feels like when I've counseled them, spent hours of my time saying, here's the right treatment, here's the steps, do this, do this, do this, don't worry, we got you. And 3 weeks later, none of it's done because it's all denied. And sometimes it's a simple appeal. You realize, oh, wait, they didn't read my note. Oh, wait, they don't have the pathology result. And it takes a burden of time from our office. Literally every day, our nurses, fortunately, who take over this duty, call in and say, why was this denied? What do you need? Oh, you're missing page 6? Why don't you just say so? Here's page 6. But sometimes beyond that, it's actually denial for the sake of denial, I feel. There's a lot out there, editorials-wise, from physicians themselves, even satire, there's videos about the humor of the process, because it literally is boggling to me that some denials happen just because they can happen. It's easier to deny and hope someone doesn't fight it than to approve everything. It's cost-saving to deny. So I don't mind the idea that healthcare is somewhat of a business, but I don't like the fact that a subspecialist saw a patient with many years of training who's not trying to commit malpractice or just give chemotherapy just because it's fun to. They're following guidelines. Their note says it all. Everything is published nowadays. These companies can look them up, but they want to make it hard. And so when it all comes down to is it's called a peer-to-peer, where a physician like myself has to get on the phone with another doctor, usually a doctor working remotely, usually not an oncologist, sometimes not a doctor, it could be a nurse practitioner. And these people usually have a script on the other side that they're reading saying, it's denied because of this, this, and this. Please submit this, this, and this. Oftentimes what I realize, and this is interesting, Bruce, I used to go into those calls extremely angry and worked up. And it's like, what are you doing? Who do you think you are telling me to do this? I'm the physician. Did you read my note? I changed that because it wasn't working. I now start my conversation in one of these appeal processes with, how are you doing today? Yeah, how can I help? Like I'm the one helping them. And often it's like, oh, we don't understand this case. What are you doing with this case? And I say, oh, this is a very nice lady. She's suffering a lot from this type of cancer, and she has a lot of symptoms. I really need a PET scan because the CT didn't show this mass, and I need that. If it lights up, I have to change the treatment. And this poor lady going through a lot with her family. If you could please help us, anything I can do. And you start like that, and you have empathy even for the reviewer who's denying your claim. Again, just think about this person. They're working probably from home, and they have to deal with really angry people, and probably rightfully so that they're angry. But I just approach it differently, and I've had like 100% approval rate. So I hope they don't watch this and hear this and realize I'm not faking it, but I'm just using a different approach. But that's the advocacy that a doctor needs to do for patients. We talk about advocacy. A patient can do that, but The bottom line is they're cut off at a certain level, whereas physicians can override it by talking to other physicians. So as much as I hate that process, the fact that it even exists in 2024 and that it's almost like a rubber stamp of denial rather than a well thought out one, I say, well, until Congress and someone else changes it, I have to deal with this. And what can I do as a person, as an advocate for this person? And the best thing I can do is to be nice, be on the phone, and vent later to my staff rather than to this person on the other side who holds my patient's life in their hands.
Hardeep, we're going to wrap up now, but what I want to do before we conclude is provide an opportunity for anybody watching or listening, if they would like to get any more of your expertise. Is there a place they can go on the web to avail themselves of your expertise?
Certainly. I write a lot of editorials and articles on Doximity. That's a popular doctor social network where, people write very good articles about what we face or what our patients face, including this whole prior auth process. I'm very active on ASCO, which is our American Society of Clinical Oncology. There's a editorial board called the Reading Room MedPage Today, where I review articles. And then I'm very active on LinkedIn. If you find me on LinkedIn, I'm under my name, Hardeep Phull. And that's where I post a lot of empowering content, but I also share a lot of other people's wonderful content, mostly examples of empathy or success, sometimes even examples of failure that we learn from, even from other industries. So I have a wonderful following on there. I really like LinkedIn because you can have a conversation about something rather than just a like or a viral video. It's more like, let's talk about this. In fact, Bruce, I think I met you somehow on
Precisely.
LinkedIn. I love the professional networking there, and it's usually very docile, usually not very political, though it can be. And so I like the professional interactions there and who I get to meet. So happy to have any patients or people reach out through those mediums.
Excellent. Our guest has been Hardeep Phull, MD of San Diego, California. And Hardeep, thanks very much. You have shared a wealth of information, stuff that can be beneficial to patients or loved ones of patients, those who advocate for the patient as the patient tries to advocate for himself and herself, respectively. So, Hardeep, thanks very much for being with us. Thanks for being with us on Cancer Interviews.
Thank you, Bruce. This has been amazing. Again, thanks again for having me.
And we're going to wrap up by saying the same thing we do all the time. If you or a loved one are on a cancer journey, you are not alone. There are people out there like Hardeep Phull, MD of San Diego, who are there to help you and provide information that can ease that cancer journey. So until next time, we'll see you on down the road.